Hello, everyone. Welcome to the Global Frailty Network Frailty Seminar Series. My name is Jorge Ruiz. I'm Medical Director of Geriatric Medicine at Memorial Healthcare System in Hollywood, Florida. And I'm also faculty at Florida Atlantic University College of Medicine, Charles Smith College of Medicine. Before I introduce our next speaker for the Frailty Seminar Series, Dr. Hendry, I would like to go on few housekeeping issues. Please use the chat button to ask questions to the speaker. I will ask the questions, I will review them before. If you are a clinician practicing in the US or Canada, you may be eligible to claim AMA PRA credits. You will receive instructions at the end of the webinar. So now I'm gonna a few words about the Global Frailty Network. We organize, of course, this Frailty Seminar Series. This is a group of healthcare professionals and researchers dedicated to frailty. And we started the Frailty Seminar Series in 2021 with the purpose of exchanging and sharing evidence-based practices and research advances about all aspects of frailty. And like in the previous 2 years, we have a renowned group of speakers who will be covering different aspects of frailty research and clinical aspects. So now let me proceed to introduce our distinguished speaker, Dr. Hendry, Honorary Professor of the University of the West of Scotland, Honorary Secretary of the British Geriatric Society and Senior Associate of the International Foundation for Integrated Care. Anne is a retired geriatrician and a stroke physician with extensive experience of influencing national policy and leading improvement in integrated health and social care for older people in Scotland. From 2007 to 2016, she held the Scottish Government National Clinical Lead Professional Advisor posts for long-term care conditions, healthcare quality, reshaping care for older people, and integrated care. This included liaison with the Technology-Enabled Care Program and the Scottish Co-Production Network. Anne is a passionate advocate for health and well-being in later life, and she led the Action Plan for Active and Healthy Aging and is a member of the Scottish Parliament Cross-Party Group on Older People, Age and Aging. As Honorary Secretary of the British Geriatric Society, she provides advocacy, policy influence, and professional advice on healthcare for older people across the UK. She has been a trustee for housing and third sector organizations and is currently a trustee director for Kilbride Hospice. She champions the lens of lived experience to inform policy and shape relational aspects of change and brings deep personal insights as an unpaid carer. Okay, so now we have Dr. Anne Hendry, so she'll be talking about integrated care for frailty. Welcome, Anne.
Thank you so much. It's a real pleasure to connect with this community of practice, and thank you for the invitation. Really looking forward to just sharing some of my insights on integrated care for frailty. I understand that you're a community who's working regularly with people who are living with frailty. So I'll not spend much time talking about the concepts of frailty, but more around how we are realising some of the new models of care for frailty. When I talk about integrated care, I'm very careful to focus on it's what's experienced by people at the point of care. It's by people and carers, and in a sense that means it's very people-centred and population-oriented. The process to achieve integrated care is more transactional, and that can require a lot of alignment of finances and governance and lots of tools and infrastructure that enables the point of care integration. I guess the whole purpose of integrated care is to improve lives and opportunities, and I see integrated care as a means to achieve the aims within the quadruple aim that in enhancing patient experience, reducing health costs or expenditure, improving work-life balance for health and care professionals, but most importantly, improving population health. And it's all about complexity, isn't it? You know that as well as I do. The concept of complex care is really live when it comes to looking at a population with frailty. And I always show my students the Alzheimer web of care, this diagram that's now been around for about the last decade. And if you put Malcolm and Barbara in the middle of the web, all of the other inputs are the supports and services and the people that are required to keep Malcolm and Barbara well, the individual living with dementia and their carer. And it's quite a complex web, difficult to navigate, difficult for Malcolm and Barbara to navigate, but equally difficult for professionals to navigate. So when you're dealing with people with multimorbidity or multiple impairments, physical, functional, cognitive, sensory, psychological, and social, that's when we really need to have good integrated care. And another map that I use is what is Judy's map. And this was a person that I met on the Isle of Man, a lady who was living with a progressive neurological condition and was supported by her unpaid carer, her husband. And again, the array of supports and services and professionals that are wrapped around the individual and that Judy and Sam had to navigate. All of this is calling out for coordination of care. What matters to older people is obviously the top of the list is always staying at home for as long as they can and remaining independent for as long as they can, able to participate, to enjoy their daily activities, and to have the autonomy and the decision-making powers. But very close behind all of that comes having care and support that feels joined up and feels integrated. What matters to older people in Scotland is no different from some of that research. I work very closely with an organisation called the Health and Social Care Alliance in Scotland, and that is an umbrella organisation that represents the voice of people living with long-term conditions and the charities or third sector organisations that advocate on their behalf. And when we asked what really mattered to older people or people living with long-term conditions, they said that coordination and continuity of care was what mattered most. They wanted to have trusting relationships with professionals that they know, that know them, and know what's going on in their lives in terms of their family, their home circumstances. And they wanted really good communication and accessible information and advice to make their own decisions. That's very similar to the what matters to people in England. The National Voices equivalent organisation to the Alliance in England described integrated care as my care is planned with people who work together to understand me and my carer and to put me in control and to coordinate and deliver services and supports to achieve my best outcomes, to help me live my best life. The British Geriatric Society did some work a number of years ago with National Voices to look to see, does that sort of description of integrated care, does it really hold for older people in England living with frailty? And they looked at the I statements that sort of describe and unpack that integrated care reality. I can maintain social contact as much as I want. I can build relationships with people. I can plan my care. My care and support help me live my best life. I'm supported to be independent. I can make my own decisions with advice and support. All of those I statements absolutely apply to older people with frailty as well. And that's why I'm confident that the global framework on integrated people-centred health services is an excellent framework with which to plan system care for frailty. At the heart of the global framework is creating an enabling environment, creating an age-attuned, frailty-informed environment that allows older people with frailty to flourish. Coordinating services within different disciplines and teams and across health, social care, housing, voluntary sector. Engaging and empowering people and communities so that people are supported to be as independent and to enjoy choice and control as much as possible. Reorientating the model of care towards more care at home and closer to home. And strengthening the governance and accountability across sectors so that where possible, there is a single budget, one team, one budget approach to planning and commissioning health and care. That global framework resonates, I think, with anyone who's trying to care for older people with complex care and support needs. And a few years ago, I and some of my colleagues at university were asked to write the first practice brief for the global framework for people-centred integrated care. And we were asked to unpack the two constructs of continuity of care and care coordination. And I can give you the link to where you can download that practice brief from the WHO site. And I'm sure that Jorge has all of these slides, and I'm sure there's a mechanism for the slides being accessible for you so that the hyperlinks are available. More recently, the WHO built on that people-centred integrated care framework with a specific piece of work around integrated care for older people. And I had the privilege to be part of some of the early work, scoping that framework at a WHO meeting in Kobe in Japan a number of years ago, and then subsequently at the Europe region meeting in Moscow a number of years ago. And that framework for integrated care for older people is heavily evidence-based. It draws on a really good synthesis of the literature on integrated care for older people. The literature looking at point of care, micro integration, and that really has informed the recommendations for managing declines in intrinsic capacity, all of the things that you should do at point of care. But more importantly for me, who's involved at policy level or at a system design level, what are the things and the steps that you need to take to design a service or a system of care in a much more integrated way? And a really nice implementation toolkit guidance is there as well as the guidance on person-centred assessment and pathways in primary care. So in a sense, we see primary care at the heart of integrated care for older people, but the recommendations for what practitioners can do at point of care, and then the recommendations for what policymakers and senior leaders and commissioners of health and care need to do to design a sustainable system. We pretty much know what works in terms of integrating care for older people. I was part of a European project from 2017 to 2019, a project that involved 23 countries across Europe. And we were tasked with developing a roadmap for what would prevent and manage frailty across Europe. And we were leading the UK was leading on the models of care work stream, and we identified a very simple framework for what works, we know that generally speaking, a single entry point in primary care is the best entry point for people living with frailty. And using simple frailty screening tools to begin to identify those at risk of poor outcomes and at risk of escalation of their frailty. We know that comprehensive geriatric assessment and individualised care plans are really important. And just recently, there's a lovely Age and Ageing paper published, which has done a detailed synthesis and meta-analysis of the evidence for community-based care planning and coordination of care, and showing the improvement in outcomes for older people and also in mortality. Provided you can not just do the care planning and assessment, but provided that you've got access to early interventions by an interdisciplinary team who can deliver those interventions using a kind of case management and coordinated approach across disciplines and across care providers. That's particularly important when people are moving between care settings, between home and hospital or hospital to care home. And it's getting the management of those transitions of care right that is really important. So many of our community-based research studies fell short because the great work that they were doing around continuity and coordination of care was not joined up with some of the transitional care or hospital at home type of interventions. And you really need to look at all of these things in the round to get an effective system of care. And obviously have a system of care that is underpinned by information technology, technology-enabled care, and digital solutions that support assisted living. The Advantage frailty prevention model was very much grounded within an age-friendly community and an age-friendly environment, taking a real public health approach to integrated care for older people. And this is a visual image of the model that we developed. I think that shift towards a public health and population health approach to frailty is absolutely critical, because as geriatricians, we see what is above the surface, we don't see what lies beneath. And I think we've now got to a point where we're more systematically identifying and case finding people who've got that rising risk and who are beginning to escalate from mild to moderate or from moderate to severe frailty. And of course, we've got a lot of tools now that we can use, like simple clinical frailty scale tool, to some of the routine data from primary care that can be used to populate a risk algorithm, like the one we use in the UK, the Electronic Frailty Index, which can identify people who need that case management or intensive early intervention. So seeing frailty as a long-term condition and using a population health management approach to stratify your population is absolutely at the heart of what we're doing now. So across the UK and our Scotland and England, Wales, Northern Ireland context, we would be expecting our primary care physicians to take their population and to stratify their population of older people into fit, mild, moderate or severe frailty, recognising it's not diagnostic, but it's helpful to inform and influence how they then trigger the earlier intervention and move to a more proactive model of care. I'm a great fan of the Catalan chronic care model, which is applied to both adults with multimorbidity and older people with frailty, and also to palliative and end-of-life care. So it's taking that kind of population pyramid and segmenting the population into those different streams. My colleague Miguel Angel Mas hosted a study visit for me last year, and I was really inspired to see the great work they're now doing, where they're 3 levels: at the level of the primary care centre, at the level of the locality or neighbourhood, and at the level of the acute hospital. There is that multidisciplinary team that is meeting and discussing proactively early interventions for the high-risk population with escalating frailty. And this is very much the kind of approach that we're seeing across Europe, and I know that you're taking forward in your context in the US. When I was going through the European project, I was working with colleagues in France who were implementing what they describe as their PREERPA model, which is all about autonomy for older people, and that's applying a case management model and a clinical coordination model for older people with frailty, and providing and delivering all of this within an integrated network of providers across different care settings. I mentioned earlier that I think getting the transitions of care between home and hospital right is really critical, and as part of our work in the European project, we did a Delphi study, an international Delphi study, looking at the definitions for transitional and intermediate care. And we also carried out a scoping review looking at some of the evidence around what worked. That scoping review has been overtaken in recent years with the emergence of the hospital at home literature, and more recently with the growth of virtual wards. But there's really good lived experience of implementation, and I always point to my colleagues in South Korea and Finland, who really forensically went at the rehabilitation model, the reablement and rehab model, and really invested in that in the community setting for their largely rural population. And they had some very significant outcomes in terms of value for people, in terms of reduction in disability, value for the system in terms of reduction in those who need to be conveyed to the emergency department, reduction in costs for the acute system, and a reduction in long-term home support when people were able to have a reablement package that encouraged and promoted their recovery of independence. Across the UK, we're very much implementing that intermediate care model, but trying to use the intermediate care model to bridge the proactive primary care and to link with the secondary care specialists who are increasingly offering a virtual ward or acute care at home. An example from colleagues in the south of England, they talk about their community frailty team, where they have a number of local community hubs supported by an interdisciplinary team, either led by a nurse or an allied health professional consultant, working very closely with primary care physicians with a special interest in frailty, and also with their acute hospital colleagues. And they are combining that intermediate care model along with hospital avoidance, a hospital at home, and really showing some great results in terms of supporting people to remain at home for longer. Great advocates of this model are my colleagues from Parc Sanitari Pere Virgili Hospital in Barcelona. Don't know if you've had any inputs from Professor Marco Inzettari, who has developed a really super acute care at home model, which is very much based on person-centred care and in comprehensive geriatric assessment and the promotion of a multidisciplinary integrated care model. Many of these models are completely aligned with what we're trying to do in acute care. In the British Geriatric Society in the UK, we've got a focus on trying to prevent deconditioning in hospital, trying to improve the models of perioperative care, and trying to prevent or identify and detect and prevent the onset of delirium. And I think you've got contributions from my colleague Simon Conroy, who'll talk more about what we're doing in acute care to identify and manage frailty. Another care setting that's really important is providing integrated care and support for older adults with frailty who are in care homes. And although we don't use care homes a lot for post-acute care and rehabilitation, we certainly see the opportunities for people in long-term care and care homes to have a more integrated wraparound model of care. This is an image from our healthcare framework for older adults in care homes in Scotland, and there's a lovely model of enhanced healthcare support for care homes that has been developed in England, and a BGS publication called Admissions for Care that you can dip into. Again, common imagery here where we're seeing a wraparound model of care wrapped around the older person with frailty and trying to support interdisciplinary relational practice to meet their needs and deliver the outcomes that are important. And finally, the other level of system that we need to work at is not just the enhanced care at point of care in long-term care settings, but seeing long-term care itself not just as a destination or a care setting, but as a system of care. And I really like the direction of travel that the WHO has taken, where we're looking at this as healthcare, social protection, long-term care, working very much as a kind of collaborative network and working with older people and caregivers, or the unpaid caregivers themselves. Our own British Geriatric Society offer in this context has been to design our own wraparound care model that we published earlier this year in our BGS blueprint. And this is Pip, this is our person with frailty who touches many of these different touch points in the system. And rather than having to be navigated from one bit of the system to the other, we believe that we have to wrap all of these elements of services and supports around PIP in a very joined up way. So joining the dots is the name of our BGS blueprint. Some of the countries that are really doing this at scale, I think, are the current reform in Finland. I talked about South Karelia earlier on, but South Karelia has now gone on to really design a very integrated model where well-being, primary care, rehabilitation care and acute care are completely joined up within the same sort of ecosystem. And the national reform that's underway in Finland is very much to enable this sort of model. And similarly, I work quite closely with colleagues in IFIC's hub in Canada. They're based in Toronto, but working with other provinces. And the Ontario Health Reform is very much looking at building what we call Ontario Health Teams, where you've got a continuum across primary care, hospital services, mental health, long-term care, and home and community-based services functioning as a place-based network. And so integrated care seems very much to be the landscape wherever you go. I'm just going to close with just a bit of a summary of what we've been doing in Scotland around this journey. I was clinical lead for the Reshaping Care for Older People programme from 2011 to 2015. And the purpose of that programme was to try and shift the locus of care from institutional settings to more care closer to home, and to shift the focus from reactive services to much more proactive and preventative services. We were aiming to do that in parallel with our digital health and care strategy, using the might and the power of digital health solutions and digital care solutions to support people to have greater functional ability and independence. We still feel we've got a lot more to go in that programme. Although the funding concluded in 2015, the ethos of the programme lives on. We have been able to quantify and demonstrate some shift in the balance of care at country level, which is quite significant. A reduction in the emergency bed days occupied by older people, a reduction in the long stay hospital bed days and in the bed days spent in care homes. And overall, every day older people in Scotland are spending more time in their own beds, and that's to the tune of about 10,000 more older people in their own beds every day than we would have expected. But we're not done yet. We're still on the journey of reform, and I'll signpost you to our policy paper in the International Journal of Integrated Care, where we're looking at what's next. And what next for us is some further reform around governance and accountability and funding, and a particularly more investment in the social care sector as a more fully equal partner to healthcare. I've sketched out some of what I see as the important learning points and building blocks of integrated care for older people. Of course, it's not just about older people. Integrated care for adults with multimorbidity, integrated care for children and young people who often have complex needs and need care to be integrated fully with educational partners, integrated care for people with mental health problems or people with learning disability. So the International Foundation for Integrated Care has a website and lots of tools and resources that you can dip into that particularly describe the 9 pillars of integrated care. I'll just end with a little bit of an advert where the International Foundation for Integrated Care has an annual conference every year that's somewhere in Europe, and next year will be in the UK. It will be in Northern Ireland in Belfast, and the call for papers is out. I have the pleasure of convening an international special interest group on integrated care for older people. So if you think this is your thing, then get in touch with me, or even better, put an abstract in for Belfast, and perhaps our paths might cross next year if you make the journey over. So I'm going to stop at that, because I was hoping to speak for about half an hour and leave plenty time for some discussion, some questions if you want it to be questions, but let's view this much more as a bit of a discussion.
Thank you, Anne. Thank you for an illuminated presentation. I think there are some questions coming. I have a few questions on my own. So why don't we start with Dr. Amani Ali. Numerous research highlighted the importance of integrated for frail older adults. However, there is no guidance on what is the most, I guess he's probably addressing the problem that we should be targeting first, maybe. What is the most important aspect that you should be focusing on? Functional, social, mental, or physical?
Yeah, a great question. And I've spent my career being asked by chief executives, what's the silver bullet? What is it that we need to be investing in that's going to make the biggest difference? And the reality is that you need a balanced, proportionate investment across the continuum of care, from prevention to proactive primary care to transitional care, and getting the model of care right within acute and long-term care. So in a sense, that's why we published our BGS blueprint. That's the message of the blueprint, is forget the silver bullet. We need to think about proportionally investing in the whole of the ecosystem, because of the interdependency between all of these different interventions. If you were really pressing me about where you should invest to see quick wins and to give you some headroom to be able to maybe then invest in some things that have a longer lead time, I would say seriously invest in transitional care, in intermediate care, including hospital at home, but not exclusively hospital at home. Absolutely hospital, the opportunity to prevent avoidable hospital admissions, but allied with rehabilitation and reablement at home and closer to home. That will make a quick impact on your institutional care flow and demand, and that will give you some of the headspace to be able to make some of the longer term investments that you need.
Great. There are more questions coming, and a very interesting question. And I guess the next question is particularly interesting, I think, for everyone, but for me, and it's talking about the role of technology. And I think if we learn something from COVID, is that technology and telehealth in particular became very important and relevant to the care of patients in general, and particularly older and frail. So how can technology and telehealth be integrated into the healthcare model to support the care of frail older adults and improve accessibility to services?
Oh, there's absolutely huge opportunities here. I think geriatricians have been a bit conservative in their response to embracing telehealth. Less so in terms of telecare. Many of us see the applications of telecare and assistive technologies to enabling independence and safe home living. But I think we've been reluctant to embrace the telemedicine, the telehealth applications. And partly that's because of digital literacy and indeed digital poverty. And sometimes for Scotland, which is a country with lots of remote and rural and island settings, sometimes it's about bandwidth and the availability of connectivity. But we have really done a lot of work to try and change that perspective. And now I think with the pandemic, we're seeing that professional to professional consultations and decision support are now routine. So having a geriatrician in the acute setting, perhaps having a video consultation with primary care colleagues, sometimes having that directly with the older person as well, if there's either a family member or a care worker who can support the older person to get online and to engage in the consultation. Older people don't travel well. We know that it can be difficult to get to a hospital or a clinic setting at some distance. But even if it's around the corner, if you've got high levels of disability and need significant infrastructure to get you from A to B, then having remote consultations is hugely powerful. I think there's loads that we're doing in the area of falls prevention, falls detection, using sensors to be able to sort of look at high risk people and to try and be much more proactive in our response to those who are maybe triggering their sensors. An area that I've been really impressed with is we've had telecare in Scotland for decades, but traditionally it has been a reactive telecare. You press your community alarm, you get to speak to somebody and they respond to you. We're beginning to shift to a more proactive approach where it's outbound calling to the home on a regular basis to build that relationship and to support well-being. So I think there's massive opportunities around digital solutions for health and well-being that we can apply to older people with frailty.
Another question. Are the needs for integrated care for frail older adults different from the needs for integrated care for adults in general? And I guess probably talking more about older adults that are not frail. If so, what are the key differences?
Key difference for me is around the fact that older people with frailty need support to address their functional impairment. So people with multimorbidity, absolutely, as the question suggests, they also benefit from integrated care. but it's the integrated care with an enablement component, with a rehabilitation and enablement component that is so critical, I think, for people with frailty, and also recognising the combination of cognitive impairment and physical frailty demands a particular nuanced approach, as well as this recognition that there needs to be support for communication for people with sensory impairments.
Another question, actually, we were talking earlier about ALMA, and this is Dr. Parodi from Peru, and he's a member of ALMA. Please comment about how to build integrated care in remote and rural cities. You talk about Finland and Scotland, but I think that it's important for many parts of the world. So.
Yeah, no, absolutely. And I think wherever you are in the world, workforce is a huge challenge. Even in large urban centres, we're finding that we don't have the comprehensive skill mixed workforce that we really require for this aging population. So I think remote and rural settings have shown us the way to be more creative in how we use the workforce and how we use the breadth of the skill mix of the workforce. In some of our island settings in Scotland, we would be using nurses and allied health professionals who are working to the top of their licence to do some of the things that traditionally doctors have done. So I think being creative around workforce development and being creative around the use of remote decision support and video conferencing and telemedicine offer some of the solutions for integrated care in remote and rural settings.
Another question, I think you touch upon the home hospital program. Actually, it started in the UK and became a little bit more popular in the United States with the Johns Hopkins group that published a lot on that. But I think this question refers to that. What strategies are effective in preventing hospitalizations and reducing healthcare costs for frail older patients within an integrated healthcare system?
Yeah. So there's probably two levels to that response. One is that there is that investment in hospital at home, that is a very tangible alternative to emergency conveyance to hospital. So that is an evidence-based intervention, but it still is a bit of a niche. It's not for everyone. And I think it's a mistake to think that that is the main basis of your attempt to develop a more sustainable healthcare system. So hospital at home is one component, but it really needs to go hand in glove with rehabilitation, investment in rehabilitation and recovery to try and get underneath that cyclical decline that we see so often in older people with frailty. If you prevent the hospital admission, that's great, but what are you going to do to prevent the next hospital admission being necessary? So it's hospital at home allied with that rehabilitation and recovery investment, making sure that those with the most complex care and support needs have a key worker or case manager who coordinates the care. And something we believe a lot in Scotland and indeed, you know, I think it's a global phenomenon, is the harms associated with polypharmacy and attention to detail about polypharmacy and making sure that the polypharmacy is appropriate and deprescribing where it's appropriate is a really important strategy to contain health costs, the prescribing budgets, but more importantly to reduce avoidable harms for older people. So there's probably a lot in there. There's the hospital avoidance, there's the rehab recovery, there's the proactive case management allied with polypharmacy optimization.
And many more questions coming up. You talk about integrated care in care homes. What is the cost benefit of this? How do you convince policymakers to invest in this system?
again, there's probably two levels to this. There's what can you do with the current workforce that doesn't require an injection of cash or additional staff? So in my experience, the staff who work in care homes are passionate, they're committed, they want to do the right thing for the residents who are often very vulnerable, many of whom are in maybe the last months or certainly years of life. So a really cost-effective intervention is to build the capability and confidence, the knowledge and skills of the existing workforce to do the right thing. So that's where I would start. Now, in addition to that, you want to try and have a facility that can reach into the care home to support the care home staff and maybe the primary care physician to make the right decisions, make what I would describe as realistic decisions that are proportionate and balance the benefit and burden of interventions. And that's where you begin to get the return on investment, because you're taking a very person-centered, shared decision-making approach to care towards the end of life, and you're stopping unnecessary, burdensome treatments that are really adding no value to the older person's life experience.
Another question from Emmanuel. What are your thoughts about the ICOP approach from the World Health Organization? You mentioned intrinsic capacity and integrated care for older people. Do you think it is feasible to manage an integrated care plan in primary care?
Yeah. So I'm probably closest not to the primary care pathway guidance. I'm closer to the services and system guidance, and I really like that. I think it's very pragmatic, and I'm working with a country at the moment where I'm pointing to that ICOP guidance on services and systems to help them design the integrated services and systems that they need. I think one of the challenges around the ICOP guidance for primary care is, do we have the right workforce capacity in primary care? And in many places across the world at the moment, we're struggling with recruitment and retention at primary care. And so it's quite difficult at this moment in time to get primary care physicians focus on that. Even in Scotland, where we've been at this for a long time, when I speak with my primary care colleagues, they say, yeah, we want to get it right for older people with frailty, but we're drowning in people with mental health issues, with inequalities, with adults with multimorbidity, with alcohol and addiction needs. So we've not got time for that stuff. So I think we need to be quite careful in the way we land it. The guidance is good. It's how we land it in a way that is feasible for primary care to engage, and perhaps we're looking at a kind of enhanced primary care model where we're looking not just at the primary care team, but what can we support the primary care team with in terms of community and voluntary sector support. We've got some interesting conversations about community-led solutions. So instead of always defaulting to primary care, how can we develop the social prescribing infrastructure where people are signposted to community supports and other well-being supports rather than always having to have a healthcare intervention?
Great. The next question must be from a US clinician. It's from Ben Seligman. Thank you so much for your talk. The examples you give largely seem to draw on single-payer systems. Could you give us some thoughts on or examples of implementation in less centralized or fee-for-service systems like the US and many other countries, of course, where competing providers may cover the same geographic area?
Yeah. No, you're up. Great question. And in a sense, where I've been working has been largely within those sort of public services. the sort of beverage type systems. My colleagues in Germany are doing some great work, and they have a very different system. They've got a sort of national insurance-based system, lovely examples of integrated care, not specifically for frailty, but integrated care and population health, from colleagues in Germany. In Australia, I think, is probably the one that I would point you to. They've got this sort of federal state system, and they don't have a very well developed primary care system. They're trying to introduce the sort of primary care home model, but an individual in Australia can have a number of primary care physicians. So it's much more complex to introduce this model within those systems, but it's not impossible. In November, the International Foundation will have its Asia Pacific conference hosted in Sydney. Lots of examples at that conference around alliance contracting. So how maybe we don't have fully integrated governance and budgets, but how different providers can form an alliance around a population in order to sort of deliver the desired outcomes.
Great. Another question, how can patient and family engagement be maximized within an integrated healthcare system to ensure patient-centered approach for all adults with frailty?
So important question. And, we talk a lot about engagement, empowerment, and co-production. The words strip off your tongue. It's actually much harder to do in reality. And I guess what has helped me in my practice and with some of our reform is investing in capacity building within the patient and carer advocacy arena. So we work closely with the Health and Social Care Alliance, the voice of lived experience, and for example, our integrated joint boards will have on the joint board not just health and social care managers and local government and local NHS chief executives, but it will have the voice of lived experience who are supported and helped to feel empowered to hold up the mirror and make sure that the services that are being commissioned and designed and implemented are truly appropriate. But I would say it's a lifetime's work. It's not something you could say, tick, we've done empowerment, yep, we've done co-production. You've got to live and breathe it every day. It's a really hard thing to do, but it's well worth doing. Because if we get systems and services right for the people who use them, then we get them right for the professionals as well. And at the end of the day, we're also people who use services.
And the next question is kind of a follow-up on the ICOP question from before, recognizing integrated care is part of the principles of family medicine. Do you have experience with the ICOP application for screening and managing decline in intrinsic capacity? I guess that's the transition to frailty that Dr. Bushan is implying.
Yeah, no, absolutely. The ICOP screening and guidance on managing decline in intrinsic capacity is absolutely evidence-based, and it's very much at the heart of what we're doing in Scotland, what my colleagues are doing in England, and what many of my IFIC colleagues are doing across Europe. I don't specifically have personal experience of an ICOP implementation program that's kind of been led by WHO, but the constructs completely resonate with me, and I can see no issues with how you would translate that, with the caveat that I said earlier, that it's really important to make sure that you've got the capacity and capability in primary care, or enhance that capacity and capability with community and voluntary sector partners. I'll give you an example. In my neighbourhood, just in my local health system, we struggle with primary care capacity to do some of this screening and managing decline, but we have used a third sector advocacy partner who is very skilled in advocacy for people with complex care and support needs, and with a little bit of support and training, was able to undertake a sort of comprehensive geriatric assessment and then bring the results of that to the teams meeting, where the GP and the geriatrician and the other members of the team are able to determine the care plan and the interventions. So it's going back to that conversation earlier. It's being a bit creative with the workforce. Who has the skills and the assets that we can draw on, and then being a bit creative about how we use technology to enable that remote case conference, remote monitoring. And the other area I mentioned, community and voluntary sector. The other group I think that we are now using more is our housing sector partners. Every older person with frailty lives in a home, their own home, not a care home, but their own home. Some live in sheltered or housing with care facilities. The people who work in those facilities are a fantastic resource for frailty. So again, a bit of workforce development with the housing with care sector and the telecare providers is a really solid investment.
I think we'll probably take the last question in the interest of time. And again, Dr. Parodi talking about in several Latin American countries and probably many other low and middle income countries, the family bears the burden of caring for all the adults who require long-term care. And there are many legal and regulatory frameworks continue to promote this approach, probably because it's more cost-effective for them. And the visibility of the state at the same time in care services is very limited. Can you give us some, I guess, suggestions about how to advocate for this kind of change towards more involvement, I guess, of governments and institutions?
Well, I suppose at a very high level, then I would be looking to PAHO to support and champion at country level. So, to engage in that kind of policy dialogue at a country level. So look to colleagues in PAHO, look to the Inter-American Development Bank, who are very active in this area. They see that investment in long-term care is a priority for Latin America, because the more we invest in long-term care, the more resilient, sustainable will the health sector be, rather than people defaulting to acute hospital admission. So I've done some work in Brazil with colleagues in the Inter-American Development Bank, and we were looking at the model of intermediate care in the country, and also looking at how we can support a shift towards care closer to home, that reduces some of the demand on a very beleaguered acute care system. And I know that within the region there are some good examples. I think Uruguay is a good example where there has been that investment. My colleague Gaston Perman is working in Argentina in a particular part of Buenos Aires where, again, there's some great investment. I think Costa Rica is a super example of where integrated care has really taken root. So I would point you to probably, again, another advert for the International Foundation for Integrated Care. I would point you to the IFIC hub in Latin America to connect and get lots of champions on board who can be part of that conversation and advocacy for integrated care in that particular region.
Well, we're going to end, and thank you again, Anne, for an excellent presentation and discussion. I think it was very illuminating to have all these different perspectives, and I think they benefited from your experience with integrated care. We appreciate, again, your participation. And for everyone, please, if you are a US or CME physician, we'll send you instructions about how to get CME credits. And I'll remind you about the next webinar. That's going to be Wednesday, November 8th. And will be Dr. Emanuele Marcedi from the Università Cattolica del Sacro Cuore in Rome, Italy. He will be talking about biomarkers of frailty and sarcopenia, another interesting topic for us interested in frailty and geriatrics. Again, thank you for participating and take care. We'll see you soon.